line. He was on the front line and served a lot of people by telemedicine. So we respect you, sir, and it's an honor to have you here. Thank you so much.
Thank you.
Thank you so much. Next, we have Dr. Muralidhar Joshi, who is currently the president of the Indian Society of Anesthesiologists with over 20 years of experience. He is also a council member of the World Federation of Society of Anesthesiologists representing Asia. He will be presenting on post-operative pain management and early mobility in the prevention of VTE. You may now begin.
Hope is it okay now?
Yes.
Yeah, thank you. Sorry, I just missed it. I was actually supposed 4 speakers. Suddenly you pushed me into the third speaker, so that's it a little bit, but doesn't matter. So question here is, I'm going to share my thoughts. I would like to say, not discuss and all. The post-operative pain management and early mobility in the prevention of venous thromboembolism. There's so many of us keep on traveling maybe across the globe, from Europe to India, India to US, US to maybe Australia and all those things. A lot of these things keep on happening. But the one subtle difference, what we have to understand is when you're looking at all these things and all, most of us, once you sit for about more than 8 to 10 hours, 8 to 10 hours, I repeat again, you start feeling a little bit swelling in your feet. That doesn't mean it's deep in thrombosis. The question here is, I think actually that Vijayalakshmi was supposed to speak ahead of me, so that's why I did not put the, which is right. But having said that, doesn't mean that we should not start talking about that one. Let's look at the prevalence of the post-operative pain in the world as such. Is almost 70%, even the well-developed centers across the globe, wherever it is, whatever, almost 70% of patients have got almost moderate to severe pain. Moderate to severe pain. So that is the prevalence, what exactly in the world. The problem here is not the pain. Problem here is not the pain. The pain, what it can lead to. If you just look at the kind of adverse effects of post-operative pain as such, it doesn't reflect only as pain. See, question here is, anywhere in the world, the two things normally the common man asks is, how big is going to the scar, how many stitches, whether it will be pain-free. That's the one. These are 3 questions they're going to ask, and nothing more than that. They don't want anything more than that, because they don't know how was my gallbladder, how was my kidney, how was my uterus. No, nobody wants to know. The question here is, how big is the scar, how many stitches, and probably how pain-free I'll be at the end of the whole show. And same thing probably for all of us. When you travel from here to maybe US and all, how comfortable will be the journey, how comfortable my needs will be taken care, and when I land there, when somebody is receiving me, the topic ends there. As simple as that. So with this kind of all the picture, even if you look at the post-operative pain in the world and all those things, 70% in the world is moderate to severe. I'm not talking mild. Mild is 30%. Despite all the efforts across the globe for last so many years, or more than a decade, what a pain medication, what we have discovered, interventions and all. If you look at ambulatory surgery, it's almost about 45%. That means somebody with an ambulatory surgery, we're discharging them. You look at that whole thing and they're like, you think that he's comfortable. Actually, he's not comfortable. The problem here is the question is which was tried, that is stresses. The problem is, if I do like an give anesthesia for something like forearm bone fracture, the person is ambulatory. I fix the fracture, he's up and about, he's moving around, no issues. The question here is, if I operate same thing in the long bone, a femur, or probably if I do probably in onco surgery in the pelvic area, maybe I should say something like, say, for example, radical prostatectomy, with lymph node dissection, or maybe something like that, like maybe abdominal kind of thing, like pancreatic surgery and all those things. That because of that reason, patient becomes like on supine position on the table, more than 8 hours surgery might go on. It has proved beyond doubt. Anybody lying still for more than 6 hours, I'll repeat again, anybody lying down more than 6 hours, especially under anesthesia, the muscles start showing the atrophy, cells and all. There are biopsies and all those things. It's nothing new and all those things. That means the problem is the stasis. The moment you lie down, probably on the bed, of course, I'm not talking not normal sleep. I'm not saying that you don't sleep for 6 hours. No, please sleep at least 6 to 7 to 8 hours. That's not a problem because you keep on moving, taking turns, left, right, and all. That's not a problem. But when you go to flight also, how often you sat in a similar position for 8 hours? No, you get up. You go to washroom or here and there. In fact, we encourage people every 45 minutes you should get up, move around, meet people, greet people, say hello, and all those things. That's what. But question here is person who has undergone probably a long bone fracture and all those things, he can't walk around immediately. So there is a stasis there, which is stasis means because of, see, for example, the heart, we say it pumps from here. But question second heart supposed to be the gastrocnemius muscle. That's what I would learn from medical students. For example, see, imagine one pumps blood to the legs. There has to be one more heart in the legs, which pumps the blood back to the heart. So that's a gastrocnemius. That means if those muscles don't contract, that leads to stasis. So that leads to then second one, stasis happens, they're hypercoagulate because what happens, person doesn't take anything, a lot of immune mediators get released and all those things. That leads to a lot of hypercoagulability and all those things and all. And because all the toxins get accumulated, there is intimal injury. That leads to additional stasis. The question here is, if you allow somebody to lie down, how often have you seen an elephant lying on the floor or maybe a horse? Let's learn from animals for a change. So normally we keep on training the dogs and the other things and all maybe. But for some time, let's understand. Imagine if elephant lies down, will it not get DVT? So that's what I'm trying to say is, unless you're mobile, at least every 40 minutes, you keep on moving and all those things, it won't. But when we go for the surgical work, especially for our human subjects and all, we always do what's called risk stratification, low, moderate, high. So somebody might go for, say, for example, maybe tooth extraction. It's fine. He is mobile. He's ambulatory. Because second heart, that is a gastrocnemius muscle, that's working. That's fine. No issues. But again, if you talk about moderate kind of thing, maybe somebody wants to go for some kind of surgery, maybe something like hysterectomy and all those, cesarean and all those things. It's moderate, but depends on comorbid conditions and all. But if you look at the high-risk conditions, something like oncology surgery and all those things, where there's already tendency for hypercoagulability, we should be careful about that. But having said that, there are a lot of adverse effects of postoperative pain. So pain, if your girlfriend pinches your hand, or a boyfriend pinches, it's pleasure. But somebody unwanted person pinches, it's pain. The question here is, the pain is defined as unpleasant experience. It depends on your perception. Unpleasant experience experienced either because of what nociceptive or neuropathic stimuli and all those things, whatever you say and all those things, with or without injury. That is defined. So basically, in common man word, it says pain means it hurts. That's what it is. So how we go about the whole process is what I would like. This is the last slide. Don't have to worry about that one. I'm not going to trouble anybody over here. So this is the last slide. Don't worry about that one. So the question here is the principles of what we follow. Like the topic was very specific for me about, for example, say that the postoperative pain leading to venous thromboembolism. So I didn't want to actually wanted to have a slide, but Nandkishore said, sir, you should have some slide because students will be attending. That's fine. The prior risk stratification is we always assess person has comorbid conditions, where they're going to operate, what they're going to operate. Plan is the clear statement as good as simple is as per evidence is the anesthesia without plan for postoperative pain management is not anesthesia. Topic ends there. The topic where it starts, anesthesia without postoperative pain management, it's not anesthesia. So question here is, you can't say, I'll take you from here to probably to New York, but I don't know how to drop you back into the airport. That's not the whole process. So the plan depends immediately. We have a lot of options. We have got, say, pharmacological options, we have got non-pharmacological options, we have got some interventions and all those things. That will come to it later, not a big deal. I just want you to focus on this particular picture. Probably if you can see all of you, this particular, the primary activation, probably especially medical students, probably who have been studying the pathology from maybe Robbins' book and all those things. You can see this is the primary activation, what you're seeing here. A small injury could be a cut. But if you look at surgery, surgery also is a planned injury. Don't forget, I'll repeat, surgery is a planned injury. The question is you have to cut this area. So you have to go there. Once you cut there, what happens next is it gets the potassium ion gets released, the protein gets released, hydrogen gets released, and blood comes from blood vessel and all those things. That's the primary activation. That gets propagated. It goes to secondary activation. This secondary activation, what you can see here, like it gets propagated, goes to free nerve endings. That's where the actually all the your pain impulses get conducted and all those things, free nerve endings. Of course, that goes subsequently to the spinal thalamic tract. If you just look at here, the free nerve endings with substance P, the stimulate platelet, that stimulate 5-HT, and that stimulates the free nerve endings. Again, SP, the mast cell stimulation, hydrogen ion. Again, same thing. Same all the chemicals. What is substance P stimulates blood vessel, blood canal. So this way, they have isolated not closer than 25 inflammatory mediators. I'll repeat again, not less than 25 inflammatory mediators they have been released. They're documented, they're isolated. But having said that, just look at the options what you have. 25, I said. You have got, say, for example, right now in the world, across the globe, you have got only probably paracetamol. I'll take it that way. Maybe enzymes, you could say diclofenac, aceclofenac, or whatever the group. Then you got opiates, right? Then you got local anesthetics, right? Maybe steroids with respect to some people use it for nerve blocks and all those things. Okay. Sometimes people might use certain agents, like topical these things and all. So out of 25 inflammatory mediators, you got only 6 agents. What about the rest 20 agents? The question here is they have isolated interleukins there and the complements there. So do we have anti-interleukins? Or do we have anti-complement? We don't have those things. Even though we have to work on that one. I'm not trying to say that they're not available. I'm not putting blame on anyone. But look at, I would like to say, maybe if I have just 1 or 2 minutes, I can just complete this one. A simple example, what you can see, somebody with inguinal hernia, subarachnoid anesthesia being given, same anesthetist, same surgeon, anesthesia given, one patient is happy with diclofenac, but other patient not happy with diclofenac. Why is that so? Probably one person who is happy with this one, maybe he is a predominantly prostaglandin secretor. So that's where your diclofenac worked. Maybe other person was interleukin secretor. We should have given him anti-interleukin medication. But question here is, this was actually almost done, almost nothing new about. Almost in 2004, they did a study in US, of course. You should be knowing about that one and all. So they extracted all the things. See, you might give diclofenac somebody else. There could be blood levels only. But we say transporter. If a gene do not have a transporter which can take diclofenac to the cell, then even though serum level is both the patients, but one person will have the analgesia, other person will not have. The impact of all this, what happens is, we end up with what is called as, we might have to give prophylaxis because we don't know who is going to have pain or who may not have pain. So we go what is called as multimodal analgesia. We use as many medications which are possible. Say, for example, I might give probably the local infiltration, local anesthetics. I might give paracetamol. I might give, say, for example, opiate during the intraoperative period. I might give, say, for example, diclofenac in postoperative period. And I also would like, because all these things still may work, may not, because I still don't know about 20 inflammatory mediators. What I focus is early ambulation. Best thing is early ambulation. There was a time we used to go for sentinel axis blockade, epidural or subarachnoid block. No, the world has changed. It's because always we move from non-invasive to invasive. So same thing here is, we have come down from invasive, like where epidural catheter was, we are looking at it. We are going to more peripheral now. We look at only nerve blocks, not even epidural, not nerve plexus. You had something, we would like to go for nerve block, not just blind, it's question of image guided, maybe ultrasound guided. On the anesthetic medication also limited. How much volume we require? Where is it random 20 ml? We are going for the limited, maybe you just require about 1.5 2 ml. That's okay. Maximum I might put maybe about 2 ml. That should be enough. So having said that, so the preparation, prophylaxis, you have to do it if it is 6 hours before, whatever the low molecular heparin you might be using. You let stop it about whatever the kind of medication which are available 6 hours before you get stopped. The preparation, yes, you have to counsel the patient what you're offering, what exactly looking, and post-operative period. These days, the idea of putting in the intensive care itself is going up. We are trying to put them back into the room. No problems. And don't put the infusion pumps. They become slave to the pump. We don't want them to be the pump. We want to be themselves on their own. That's the bottom line. Early mobilization is the best thing. The precaution is the only thing is when you do nerve blocks and all, we have to prevent the fall. Somebody gets up or take care, wants to go to washroom, he might fall down. So that is the second. That's one thing we have to understand. Position, lithotripsy position, all those things can lead deep in thrombosis. Projection is only, you're not only what you're expressing, speak to the team, why exactly you're doing, why not this way, why not other way. So the team also has an idea about how to go about it, why you're doing this particular, so that same thing can be reproduced again and again. So that is what is called evidence-based medicine. Not just like that, I am an expert, no, tomorrow I may not be there. How does it matter? The patient should get the best possible care. Depending on the procedure, type specific, we have to look at the whole thing. Of course, post-procedure, you have to follow up. Was the patient comfortable? Whether we could have done much better than what we had done? How best we could have done? Or do we take more time and all those things and all? The prognosis we have to cut only is not much a problem with respect to embolism and all, but we have to cut it with the prognosis, whether by deposit local anesthetics, whether a person is going to go through some kind of changes and all those things, we don't understand. But in the given situation, best thing is play safe as much you can do. I think I'll stop at this time. Maybe I've taken more time. Sorry if I've taken more time. Thank you so much. I'll stop at this time. Thank you so much.
Thank you, sir. It's always a great honor and pleasure to hear from you.
Thank you, Nando. Thanks, sir. Thanks a lot.
Sir, Muralidhar Joshi, sir, is our guru, not just for me, for all the young pain consultants, physiotherapists, nursing staff, and current president, Indian Anesthesia Association. Sir, you have been extremely kind, and on 16th October being World Anesthesia Day, I know how busy you are with your ward work, training anesthesiologists across India. Only one word I wanted to mention to the global crowd. Muralidhar Joshi, sir, brainchild is traveling pain school. Initiated a concept of spending our own money to reach to medical schools and educating undergraduates and postgraduates and residents with our own expenses. And in that way, Joshi's idea of traveling pain school in association of Australian and New Zealand Association of Critical Care and Pain Management developed a program called Essential Pain Management and trained more than 40,000 medical, non-medical, paramedical, nursing. Huge inspiration to young physiotherapists for me, and no wonder that program won the best medical education program across the world. The book, the first book in India on pain management, written by Joshi sir, is the Bhagavad Gita for all the people who are focusing on pain. And sir, it is all